Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's episode is part one of a two-part series, helping those of us that are on the inpatient side be a bit more savvy about what our hospice counterparts are experiencing. And our outstanding guest today is Dr. Chris Schaefer. She has been an RN for nearly 40 years and a hospice nurse for over 30. Her nursing journey spans med-surg units in Massachusetts to missionary clinics in Papua New Guinea, shaped by a global upbringing in the Soviet Union, Kenya, and Saudi Arabia. Chris found her calling in hospice care in the 1990s and has since served as an on-call hospice nurse, hospice clinical specialist, educator, and hospice director of nursing. She holds a master's in palliative care and a DNP with research focused on improving hospice visit frequency in the final week of life. Passionate about evidence-based practice and mentoring, Chris is dedicated to helping the hospice interdisciplinary team stand in the gap for patients and families. Outside of work, she's a proud wife, mom of 3 grown sons, grandma of 6, and a professional photographer. Chris, welcome.
Thank you very much for having me.
Absolutely. I know we have a couple of topics that pique your interest the most. Maybe we start with the Macy catheter and see where it takes us from there.
Okay, so I have presented on the Macy catheter. You'd think I'd have stock in it by now, but a gentleman, a nurse by the name of Brad Macy, apparently pioneered the Macy catheter, which is a rectal catheter. And it looks a lot like a Foley catheter, but it's tougher, more resilient, and it goes into the rectal vault. And so what ends up happening is we have been using this, and now in the last 2.5 years, we went from zero utilization to 75 times now. And what ended up happening is when our patients get near end of life, or if there's something going on with their mouth where it's just insurmountable to have any medicines in their mouth, things that can be given orally can also be given rectally. As we know, as we say to our patients, it's the same tube. It's just the other end. So what ends up happening is we can place these Macy catheters. It takes about maybe 10 seconds to place them. They cost around $100 for the kit. And then we can administer all the oral meds rectally. Now, every doctor and every nurse is going to say, but what about? Yeah, what about the long actings that you can't crush? What about? What about? So these are things. And keeping in mind that given the opportunity in a well-planned hospice stay, a person could be put onto methadone, which is a liquid long-acting lipophilic med, and you could continue to give that hyper-concentrated form under the tongue, and you wouldn't need to give that rectally. But what ends up happening, the vast majority of our patients need to be on one of 3 opioids, and that would be the traditional Roxanol 20-to-1 morphine, or the hydromorphone 1-to-1 or 4-to-1, or oxyfast. Now, the hydromorphone and the oxyfast are more expensive. And in hospice, if people don't know this, we get one piece of money to cover everything per day. That includes docs, nurses, all of our salaries, that includes our meds, that includes everything. So we have to be very aware and very responsible for what we're doing. So if a person can tolerate morphine, we would definitely go that direction first. We can also give the liquid Haldol that way. We can give, the lorazepam. Those are usually a very good cocktail that we'll give. However, one of the really amazing things is people who go at the end of life and have seizures. This has been a huge stressor because they're no longer able to swallow. So they can't swallow, and so they've got these enormous amounts of Keppra, liquid Keppra, which is, by the way, not typically really, it's not really expensive, but it's also not cheap. And so they get off of their prophylactics, and then we're supposed to be giving them, maybe giving them dexamethasone or something like that. Now, dexamethasone liquid is a horrible tasting, and it leads to non-compliance. So if we have a person who has a little bit of difficulty swallowing, we're like, oh, it's okay. And they're like, no, you try it because it's disgusting and I'm not taking it. So we can give that rectally. And the third thing that's really amazing about it is you can give crushable meds. So you can give regular old-fashioned Tylenol. You could give many of the meds that are like metoprolol, not succinate, but tartrate. You can crush those, and you can give them, and we give them in water. And everything to do with the Macy is done with tap water. No saline, no special IV fluids. Remember, anything that goes in the mouth goes up the bum. So you would never give someone, have them drink these crazy like lactated ringers or all these kinds of different IV fluids, so that it's very affordable. So you use water temperature, I mean room temperature tap water. And it's so funny because as soon as you walk in, they're like, "Oh, it's got to be sterile." I'm like, "Look where we're putting it. We're putting it in their bottom. It is not sterile." So it's not even a clean procedure if you think about it. We always ask them, just go get one of your bottles of water or a glass of water, and that's what we use to inflate the balloon. And then also to mix the meds. So all the meds are mixed in approximately 10 cc's of fluid in the end. And then we flush everything with 3 cc's. And we flush it really, really, really hard because that way, if there are any particulate matter, we can preserve the patency of the tube. Our experiences with this are incredible because in one of the drugs that they don't have a lot of there, we need one of your research people out there to do is a trial on gabapentin rectally because there's not a lot of information now. There's lots of anecdotal information for people like me. It
Mhm.
works. It works for the crazy number of things. It can use for nerve pain. It can work for seizures. It can work for, hiccups. And now we're using it for a variety of different symptoms. I mean, gabapentin is one of those things that is evolving into a multi-use drug. So some of these things we have in the home, and it may be Saturday night. So what are we going to do? We're going to open that capsule. We're going to put it in, and we're going to flush it through. So now we can use medicines that were already in the home and we don't need to stop. Not everything has to stop. We can use what's available with the caveat and exception that we can never use a non-crushable med. So you have to go into your database online or, use your smart AI app and ask if something is a crushable med or whatever. And we work with our doctors on this. Another tip that we have found along the way is we've been able to manage two really crazy symptoms. People with glios and other seizure disorders, we can now keep them at home, bring the hospital to the home, and never drop in a line. So now I can give diazepam rectally. I don't have to go with a $300 diastat, which whoever did that to the industry is cruel and unusual. That's really awful that this incredibly affordable med, diastat, is very expensive. So we have to go to compounded things. I don't need to do that. We just get dirt cheap diazepam, crush it, put it through, and we can give that Q8 unlike the lorazepam, which wears off much faster. So we would give a cocktail of things. We'd be giving their dexamethasone that way. We can use the tablets if we don't have the solutions. And keep in mind, the tablets are much cheaper. So they also don't have a shelf life problem, right? And that shelf life is an issue. You have to know what goes into the fridge and what doesn't go into the fridge, et cetera, et cetera. So we've had this ability now to keep people at home. My first time I did this, my goal when I walk in is I want to get there. Sometimes if the ambo's on their way home from the hospital and I know they have a glio, I know they're seizing from whatever other reason. I will set it up. It almost looks like a hospital room. I have, water impermeable surfaces set up and I use a Sharpie and I write all the directions. I lay it all out. In my perfect world, the family member puts the Macy in. I don't do it.
Mhm.
I make them so comfortable that they go in and they place it. And then I did this with one family where I actually placed it because it was heavy set lady. And so we had to hold her on her side. And so it was just easier to do that first thing. I went in the next day we put 12 hours of continuous care in because she had a full bowel obstruction, this lady, and we were doing a cocktail of 4 meds for her. And we put in this Macy, we were giving the meds, we had everything on oral syringes lined up, and then we were giving the meds. The patient was becoming calmer and calmer and calmer. Went in the next day and I said, okay, I'm going to show you. Let's do this. And the lady pushed me out of her caregiver pushed me out of the way and said, no, 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 this is my job. This is what I do. And so everything worked. And there's a company, MVI, they do a really great series of teaching called the Perfect Visit Model. And they really, really emphasize the idea of make the caregiver the hero of the story.
Mhm.
So give it away.
Mhm.
So what we do is we empower the family and we say to them, our doctor is working very closely with their PRN dosing. So we have a around the clock or scheduled dose, and then we have our PRN dosing. And of course, each patient is individualized. But one of the things we have found along the way is by making the family member involved with this. Now the person can poop it out, and then we deflate the balloon, use the same one, put it right back in, and off we are to the races. There are a few times when this has not worked, and I've got to tell you that assisted livings and skilled nursing facilities are not a fan of the MACI because they're fearful. So they will allow us to come in and put it in as long as we're doing continuous care. So we have to manage it. This is one of my things. I would really love to have get over that bump. Maybe one facility and then that DON could share with the other DONs in the community. It is an incredibly helpful thing to help with our patients who have severe, severe symptoms. Even patients with severe pain, if we're giving hydromorphone, the only commercially available hydromorphone in our area is 1-to-1. That's a whole cc. So that could be every 4 hours around the clock. And then when the symptoms bounce up, they're a Q1 hour. You're also giving lorazepam, maybe a half a cc. You might be giving, a variety of other little meds and everything, and they will start to choke on it. So all of a sudden that dysphagia really comes back. They are the candidate for the MACI. A lot of times with the Roxanol is concentrated enough that we don't, but when you're getting up to 20 milligrams an hour, even that one full cc of morphine can be a problem, especially since it's hydrophilic, it's not lipophilic. We have to be very careful to not misrepresent these medicines as sublingual in the sense that they're going to be absorbed. We have to know our drugs. So lorazepam is lipophilic, and it does cross the blood-brain barrier, and it does act fast. It will be sublingual, where the morphine actually does trickle down the throat and will go into first-pass metabolism. So when we give it through the rectum, the reason it works faster is because we don't have all the gunk, the food, the spit, all the remnants of the crushed meds, go in the nursing homes, you see them crushing the meds. All that residue is filling up in their cheek pockets. And I mean, if it grosses us out, can you imagine what the families think? And our patients, they're revolted because they taste this residue, it's pricking them, it's getting under their dentures, whatever's going on. We can avoid that whole scenario by using the rectal route. So by doing this, we've had people who are now able to speak at the end of life, who are now able to interact, and really, and then it looks just like a Foley. The unit comes over the front of the leg, and it just gets, we use the same thing they use for a Foley. We attach it to the front of the leg, and all the meds are given down there 24 hours a day. They never need to be woken up again. They don't need to choke or gag. So the two big successes are people with seizures and then people with full bowel obstructions. And we give a cocktail of Haldol liquid, lorazepam liquid, morphine liquid, and dexamethasone liquid. And we use this cocktail, and we've been able to allow people to die at home. They choose not to go into the hospital to get to the venting G-tube. They choose not to go into the hospital to have surgery. They're not a candidate. They usually have profound abdominal metastasis at this point. So we've just done a really great job with helping comfort at the end of life. Now, the families have to be on board with this. They have to understand what comfort care is. They are welcome to revoke and go back into the hospital setting if they wish. But once this starts and they start to see that it's not going to cause smells, it's not going to cause this, it's actually going to be more aesthetic than this gunk in their mouth where they're trying to use the blue swabs to grab stuff and take it out. And now they've got their mouth so they can talk. So that's been a huge success. And I just really want to stress that when we admit a patient, and let's say you're a doctor in hospice or a DO or an NP working in hospice, they should write the order as PO/sublingual/PR, meaning per rectum. And that way you've got everything covered. At the very beginning, you're good to go. So I can convert that oral and start giving it per rectum. If you're really picky and you're looking at those meds, you might need to have those rewritten. Well, why rewrite them when you could just get into the new habit of writing PO, sublingual, PR? And if you write PR, it's not disgusting to the family. What do you mean per rectum? You're putting that up their bottom? Well, wait for 2 weeks. Might be putting that up their bottom, but if they ask what that is, which they won't, but that way you can avoid that little unhappiness with the families when they see per rectum when the person first comes into hospice. But one of the things we do when our admission nurses and our liaison nurses go out into the community is they actually talk about the MACI now. So they'll
Mm.
say, we have this really cool thing that we can do. We can place this so you don't have to have needles. So the really nice thing about not using parenteral, we do everything enteral, non-parenteral. So we don't even do subcut. Now I can give subcut in some other instances, but subcut is a tricky thing because we don't ever want to have unnecessary risk for infection. So it's a very helpful thing. It's very easy to do. And the way I implemented it was by saying to people 24/7, every days of the week, I will go out and I will do it with you. And I've done that. I've done it and done it and done it and done it. And sometimes you'll put it in, you'll give 2 or 3 doses, and the person will die in your arms. It can be that quick or it can be days. People at Alzheimer's, if you control the UTIs and the aspiration pneumonias in an Alzheimer's patient or end stage dementia patient, they may start having some of the other symptoms of brain failure, which is seizures. And those seizures can be well controlled. Now, you could use diastat if you wanted to, but that's expensive. Or you could get compounded local diazepam suppositories, which aren't as expensive, or you could convert to this route. So I wanted to share the importance of this because it's allowed us. I'll give you a classic example. We had a guy, he was coming from another county. And in hospice, you may not be aware of this, but you don't cross county lines. Some states, 14 states in the union still are, they're called certificates of need states. And Maryland, where I am, is one of them. That means you don't cross a line. You have a certificate of need per county. You can have many counties if that's what you've arranged as a company. So this other guy was coming and he was a man who was homeless. He was a veteran. He was a alcoholic. He had HCC. He had really bad liver cancer from a lot of his behavior. But the way he was dealing with life was just to drink. He was drinking a fifth of vodka a day. His brother found him and said, he's so sick, I'm going to pay for him to be in an ALF. Now, here's the problem. He wanted him to be in my county. So we accepted him with the provision that we were going to do continuous care and meet him at the door, place the Macy, and take care of him. And so what were our needs? We had to say ahead of time. We were worried about seizures. We were worried about him bleeding out because of the liver. He had really high INR. We were afraid of him going into DTs, from the alcoholism. So we went out there, and I wasn't able to go in person, but I'd helped a couple of the nurses who were there to place it. So I actually just had to close my eyes and do it in my mind. And I helped them through it all. They placed the Macy, they administered the meds, and the guy was there, and the man who was dying. And he opened his eyes and he looked at us. And it was a really, really profound moment. He says, this is the first time I've been out of pain. Everybody who meets me judges me. Everybody who meets me tells me what a bad person he is. Do you think I don't know that?
Mm.
Do you think so in hospice, the very first thing we said was, we're not going to judge this man. We're going to administer these meds so that he can have a peaceful death, because we knew he was close to death. So we went ahead and we administered the meds, and he immediately was so much more relaxed. It was, I believe, for him, it was a hydromorphone and lorazepam and dexamethasone for him. So we went out there. We were able to administer those meds. We settled in, and his brother was there. And so one of our on-call nurses, who's amazing, came. So they keep giving the meds, keep giving the meds every whatever 3 or 4 hours, NPRN when he had a breakthrough pain. And she sat down and she said to the brother, I think that what you need to do, because the man had matted hair, his whole body was filthy from living on the street. They bathed him from head to toe. And they just bathed him while his symptoms were controlled. And the guy was just crying, the patient, because here he was. His pain was controlled, and we were bathing him and treating him like a human being. And he ended up dying within about 4 hours of admission. And his brother, we gave a gift to the patient, we gave a gift to the family, and we were able to secure so that he did not have to go through, any DTs. And he had gone from this enormous amount of alcohol into nothing. And so we were very worried about that. So I just wanted to give you an example of one of the things that we were able to do that was very successful with the Macy catheter, other than our complete bowel obstruction.
I would expect a fair amount of resistance, but it doesn't sound like there there is when the rubber really hits the road and it's needed.
There it is.
Yeah.
So and here's the thing. If you exude confidence, it will come across. So as a doc or as a nurse, a senior nurse like myself, I go out there and I say, we do this all the time. This is very effective. If it hurts, we'll take it out. Usually what happens is the patient's like, when are you going to do it? Now I've already given it. I've given them the meds and they're like, I'm like, okay, did that work? Yes. So
Sure.
usually I try not to make a big hullabaloo over the actual
Okay.
insertion. And it's very effective. But I think that what it's all about that compassionate pre-conversation, setting the stage, letting them know that this is an option, that this is something our doctor may order. And occasionally we'll have a family who doesn't do it, but most of the time they do.
All right. I want to be mindful of time. How about we tell us a little bit about this nurse residency program?
Okay. So in hospice, in all of nursing, there's a shortage of nursing. The world is getting older, the world is getting sicker. The nurses are aging out, I should know. And what's happened along the way is the nurse shortage has made so that there's not a lot of nurses wanting to go into home hospice. Home hospice is paid differently than home health because home health is they're paid per visit. There's a lot of differences in how these are. So to bring people in, I need to get younger and younger nurses. The problem is traditionally hospice nurses come into hospice nearer the end of their career. They're wiser, they're older, they want to do one patient at one time, they value all those things. They're not interested in ED and ICU. They're tired of all that. They don't want the adrenaline. They want to do real holistic nursing. So that's traditionally where it's been. But now we need to be able to pull in the younger nurses. The question in all this is how to get them to go from being acute care, boom, to palliative care. It's a complete turn of how you're looking at it. We're no longer trying to cure and we're trying to palliate. And so that's a whole different set of skills. A lot of them are very, very medical skills, very physician skills. We're using validated tools that the docs use. You guys know e-prognosis and all those different validated tools that we use. And we have to take them from being nurses into being evidence-based nurses who say, I'm going to look at every case and I'm going to learn what I can about it. If I need to learn some pathophys or whatever it is, I'm going to ask my doc to teach me, my senior nurses to teach me, and I'm going to get so enthralled about this case that I'm going to win and I'm going to come in. So for my nurse residency program, we walk in and in a perfect world, we meet once a week with our newer nurses, our younger nurses, and they come in and we do case studies. So we would do like a grand rounds. I'll say, well, we had this patient come in, they were, whatever, 68, and they had like the case of the guy who was an alcoholic. And we talk about it, we show the labs, we say, so when you see this, when you first hear about this patient, what are you going to look for? We're going to say, first question for any hospice nurse, where are the dark towels? Because he's going to bleed out. And he was trickling out from his bottom and also from his mouth at the end of life, but he never hemorrhaged. So we're going to say, okay, we're going to go one step beyond the dark towels. How did we teach the family? What did we do? What did we do to mitigate it? And then we're going to go through and talk about, has the person been on anticoagulants? What's going on? And all these kinds of things. And we teach to every single aspect. So taking a case and running it all the way down to when they pass away, successfully or unsuccessfully, or fully palliated or not fully palliated, with the nurses once a week, and then saying to them, what are some really, really important points here? So we have to teach the nurses, but I find that doing it in a very classroom setting is it's very sterile. I have to say, we had this patient and this is what happened. And this is how the doctor reacted. This is how the nurses reacted, how the social worker, how the chaplain reacted, and in the total. And so by doing that, we're trying to keep them, number one, in the program, but we're also trying to rapid track them from going from curative to palliative therapy. So with palliative, of course, we know that what are the goals of care? And every palliative care doctor is out there going, preach it, sister, right? What are the goals of care? So if the goals of care is to get up and rise up and walk and go get more chemo, we got a problem. We have a big problem. And that's a legitimate, hope-filled conversation where they may need to leave hospice. But if they're on our page, if they're on the palliative side or the hospice page, as we call it, then we have a lot of room where we can work with them. And I would say 80% of our job, 80% of a hospice nurse's job is education.
Hmm.
kind, compassionate, proactive education. And I've been developing an enormous number of teaching tools to that end, so that we can go out and say, why do we give low dose morphine? Because we know that critical conversation. You've got your classic dementia patient. He or she comes into the program and now they're having terrible pain. Every time you move them, they're yelling out. And so our doctors say, let's try some, Roxanol or morphine, 5 milligrams, which is this tiny dose, Q 4 hours around the clock or whatever they've decided to use. And then the family goes, morphine, not morphine. It's the M word. You're trying to kill my family member. And then you have to go into finding your words. And I've developed some tools that 5 milligrams of oral morphine is equivalent to about one Percocet, or we know one oxycodone 5. But most of them know more that what a Percocet is. When you go to the dentist, sir, ma'am, you're taking 2 Percocet. So don't tell me we're over medicating your loved one. What we're trying to do is suppress cough and that air hunger, these things that they're coming up with. So we teach them all about these things. And so that's what our nurse residency thing is all about, is telling them that in like ICU, you're hanging, you're doing this beeping and all this other stuff. And we're saying is calm down, sit down, have a cup of coffee, have a glass of water with them, and find out who is the person in the room who's resistant to the morphine. It's usually one family member. It's usually the one that lives in another state. It's not usually the one who's watching mom scream in pain.
Yeah.
And so you can get on a Zoom call or you could do what you need to, but finding out who that is. And I've got to tell you, having the social worker and chaplain there at the same time is incredibly helpful. So to have it a collaborative thing and our physician either in person or by the same Zoom call, it could be incredibly freeing. So for us, we try to empower them, try to give them the tools. I do so much with evidence-based practice. I like them to look at the fast facts from Wisconsin, the Palliative Network, and send those things out. And then this dovetails beautifully with the Hospice and Palliative Nurses Association certification program. So then when they get a little bit more mature and have more hours under their belt, we can go into that. And then we kind of go into more of a didactic world and they take an exam to become certified. And when they do that, almost every hospice agency, their rate of pay goes up and they're seen as more of a senior clinician. So trying to do that, we know that in ICU, CCU, all these things in the ED, they all have their initials after their names, but we get our initials. And ours is CHPN or CHPLN if you're an LPN or whatever it is. And even our nurse aides can get certified in hospice care. So what we're always trying to do is push them higher and harder and saying, this isn't where nurses go to die. This is where nurses go to become autonomous,
Yeah.
empowered, and working collaboratively with our docs.
So we're retraining the role, we're promoting curiosity, we're working at the very top of our license, we're gaining
That's right.
expertise, confidence, and still there are times when sometimes the hospice nurse calls
Yep.
the doc on call. And I remember when you and I were talking about planning this months and months ago, you shared sort of a horror case of a nurse who called a doc, and I think it is nice to hear it from your end of how do you want the hospice doc to pick up that phone when the nurse calls? What should we be retraining
Oh,
our mind so we're not, biting somebody's head off?
mhm. Well, my biggest thing is for my nurses, I'm trying to tell them to do their assessment before they call, do their SBAR before they call, even if it's not on paper, to be prepared. If you're calling about you want to titrate something or whatever, you better have those pain measurements or their dyspnea net measurements or what you're seeing ready. But if a nurse calls you and he or she is panicking, which is and the newer nurses will do on occasion, is I guess my answer would be kind. You were there once yourself,
Hmm.
and that you're not there. You are not there with 14 people looking at you, screaming at you. I just want to send him back to the hospital when you know that this patient expressly did not want a medicalized death. You know that they have their terminal respirations, the death rattle. They are showing, a pain ed score of 0, but whatever the other symptom is that we need to be controlled, and just trying to empower that nurse to be able to say to them, him or her, it's okay. Um, I would love to talk to you about this, but I need these 3 pieces of data. I need to know how many doses of Roxanol she's gotten or he's gotten in the last 24 hours. I need to know these things and then bring it down and then bring it down, and then possibly talking to the nurse manager later saying, can we please create a template or a way, an S bar that we need for this? But the worst thing to do is, of course, is to yell at a nurse, because then you've made an enemy for life, right?
Mm.
And it's because we react from a different place. We feel very much like we are protectors of our patients. We see a problem. Maybe we can't articulate it at the moment because we're younger in the profession, in this chosen this specialty. But maybe just to be kind and say, what are the assessments that you need? What are the vitals you need? What are the amount of meds that have been given? What is available? Because so often the doc will say, well, we need this. I'm like, you do know it's 4 a.m. This is all I got. I got these 3 meds, and that's all I have. So what can we do until the sun comes up and I can get to or the family can get to a pharmacy? So a lot of it has to do with, hey, I really understand. Can you step outside? Can you go where the family can't hear you? Can we just talk about this a little bit and find out what are your thoughts? And hopefully the doc can get into the EMR. Hopefully the nurse has been in the EMR and looking at all this stuff. And then most of the times, the nurse will be able to calm down and say, this is what I need. But hopefully they're going to be calling you with the right assessments, because we are your eyes and ears.
Yeah.
Well, if you're not there, you have to trust the nurse. And it's hard sometimes to trust the nurse if they're green or they're panicking.
For 10 years now, I've been trying to get better at responding to pages, and it is a slow process, but I am trying to train my brain to reflexively, when I get that call in the middle of the night, which is on the inpatient service, different world, but still, to the first thing that's got to come out of my mouth is thank you for calling. This must be important. And that sets then the tone, right?
Uh-uh.
It's kindness. I'm not very good at doing that every time, but I'm working. I'm working on
Yeah.
it.
Our doctors are phenomenal, and you're going to find out anybody who goes into hospice, like true hospice, generally they're very kind-hearted people.
Sure.
And very good. Every once in a while, you get someone, like you're saying, when you get woken up and you're like, you called me, but you don't have all the data I need. And just sometimes we'll say, just hang up, just say, hey, can you gather this data and give me a call back in 5, 10 minutes, and maybe we'll be able to talk a little bit more.
Sure.
But yeah.
Let me ask you just one more
Hmm.
question, then we'll try to get to some of the audience questions in the chat. There's so many things we could talk about. The thing that interests me most, because I personally deal with this, is this advanced directives that require double certs of
Hmm.
incapacity. Let me tell you what I experience. I want to get your perspective, and maybe there's something I'm not appreciating here. So I know that some of the hospices that we work with here in Milwaukee will ask one of us to provide one of the signatures for cert of
Yeah.
incapacity when
Hmm.
somebody does not yet incapacitated, knowing that there may only be one clinician. And ethically, I struggle with this because the
No.
form says that I'm certifying that they're incapacitated. Help me have more
So
appreciate the other side.
I can't even imagine a more unethical request.
Sure. Okay.
We would never ever do that. In fact, we're so meticulous with our incapacity certs
Hmm.
that, our docs and occasionally one of our NPs will work on these things, but sometimes they'll say, no, I can't do that. They're not. So, but if they come in from the hospital and there's one already on their record, we might use that. But as we know, people wax and wane.
Hmm.
Their ability to interact sometimes can wax and wane depending on how ill they are, if they're not in the dementia situation. But yeah, so we are very careful about our double certs. And then um, it's been a huge process. We've had a wonderful director of admissions who has been teaching and giving the words to our admission nurses to help them navigate that, because we would never do what you just said, ever.
Okay.
Because how could you do that?
No,
That's
I
You're
personally have
asking you to
never done
sign
it.
something that's not right.
Yeah.
In the same way, if one of our physicians says, I think that someone's term is continuing has continuing eligibility and the other one doesn't agree, then they have the right to not sign that. They're not going to attest to it. But if the other physician can do that. So once again, we all come to that just like doctors with the PDMPs. If you do not want to prescribe or you feel uncomfortable prescribing an opioid or a benzo, you can recuse yourself. You can say, I'm not, that's why the pain clinics and that whole dynamic between docs in the hospital and the pain clinics and all this other stuff come up is that, yeah, sometimes we're just not comfortable or we feel like something is pushing our ethics buttons.
Hmm.
Uh,
Good. I'm glad to hear we're on the same page then.
Absolutely.
Perfect, perfect. All right.
They're meticulous here with that. Yeah.
All right. There are two questions in the chat. I want to try to get to each of these and then we'll send you. So, a question for Eve says, looking for advice when using Macy at facilities. You stated your company provides continuous care. How do you address if the dying process is prolonged?
This is a huge question. So the question is to talk to the DON, ADON, perhaps the medical director at that facility and say, um, we can place this and we can teach you guys. Let's do a 12-hour continuous care and teach you because there is nothing that says you can't use this. This is the rectal route. They give suppositories every day. They
Hmm.
give enemas every day. To pretend that this is now some new thing, it's not. So it's how you, the teaching to that facility is going to be all the most important thing. And it's going to be the biggest impediment is that DON is going to say, I'm fearful. I don't know what this is. So can we come in and teach you? Can we come in and be the facilitators? Maybe you could pick one senior clinician or someone that we could teach you. But there is no easy answer to that. When they have a prolonged dying process, the answer is really, really potent because if the facility isn't going to do it and the family is not allowed to give it, it's not an ALF where the family can give meds, and they're in a sniff, then you're going to be having trouble if you don't navigate that ahead of time.
Thank you. Jake asks, as someone who trains chaplains and works in an assisted living continuous care facility, what are some of the ways you would recommend for building confidence? I see your anger, experience, passion is something that fuels you. What would you recommend for long-term care facility staff?
In what respect? Relating to what specifically?
Specifically, putting in Macy catheters.
Oh, okay. Yeah. So our chaplaincy, our staff, it's been very interesting. I'll actually have them call me and they'll say, well, we think that this person needs to have a Macy because they're gagging. They can't absorb the fluids or they're so dysphasic or whatever the reasons are. So for the chaplains, you would have to go from the perspective of is there a problem with their particular faith base? Is there any violation if you're, say, a very observant Jewish gentleman or a lady or any other, Catholic or Protestant or any other faith? I have yet to see an objection from that perspective. So for me, it's an aesthetic thing. And what my teaching point would be is if we were able to get this implemented, the person would be much more, and they can walk around. People can walk around with this. There's no problem with any of that. They could be in their wheelchair. They can do whatever. And so it would allow you to have more of an organic interaction with with the patient and the family without anything on the face and jamming things down their throat. And so to me, that's a very positive thing from the perspective of, say, chaplaincy, where you're doing a lot of talk therapy and approaching it from that perspective where that's your number one, way of interacting with the patient. Does that help?
Lovely.
Definitely. I was also thinking about nursing staff, and what advice you would give to them.
So the problem is you have to give over the bump. It's like you're driving down the road and you see bump ahead. Well, that bump is going to be, they've never done it. They have that fear. They have that anxiety. Is there a policy and procedure written for that? And so that's where you could reach out to, you could actually reach out to the Macy Catheter Company. They're incredibly helpful. If they have people driving around all the time, seeing if they could do a demonstration on location or have a local hospice be able to come in and say, hey, can we try this? And they might have to talk to their medical director or their DON. I'm sure they would, and just say, why can't you guys be the cutting edge people? Why can't you be the ones that can embrace this so we don't have to use a PCA pump, which is a needle, or access someone's port and do something IV. So this is a much cleaner, more effective way of dealing with that, the really difficult swallowing at the end of life.
One last quick question snuck in, and then we'll send you. Do you have a magic phrase that can de-escalate that frantic nurse at 4 a.m.?
A magic phrase. I like what you said. Thank you for calling. I like that. But I think that the next thing that I would like to hear from a physician is, let's say the nurse calls and says something a little outside maybe their scope of practice. We need to titrate the meds,
Hmm,
right?
hmm,
Which in many ways is her prerogative to offer that, but maybe not to tell it.
hmm.
And just say, I understand where you're coming from, but let's look at this. And I would prefer to use, this around the clock or this Q1 hour or that kind of thing. For me, that I think feeling appreciated is the number one thing for me. It really is. But to ask them very kindly, if you need more data, hey, I really need to know, what is their blood pressure or what is their, what is their temperature or whatever it is that we're asking the particular PRN med for. And and then being able to interact with the data. Because if you don't have data, how can the docs respond? I mean, if I don't give you a pain ed score of 7 and the person's screaming, or the patient's on a pain ed of 3, but for them it's completely unacceptable, as evidenced by, and you need that data to go with. So I think the first thing is just to be calm, raising the voice. I've only had recently in recent memory have one doctor who really raised their voice, and they were not necessarily wrong,
Hmm,
but it wasn't the right time.
hmm.
It was the misplaced timing. And that doctor actually called me back 20 minutes later and said, I'm really sorry I did that. I said, it's not me I'm worried about. I was on with the junior nurse. We call them baby nurses. I was on with the junior nurse. He was very apologetic. And I said, but let's going forward realize that we have some tender people out there that we need to. I mean, nurses are the profession, we have a phrase, nurses are the profession that eats themselves, destroys themselves. We can be so mean to one another. So we have to go and flip it over to being kind and compassionate and educating and evidence-based practice and approaching things from that perspective. And Yeah, nurses can be really, really hard on each other. And so for me, it's about educating them and giving them the tools and saying to them, do you need me to come and walk alongside you and come shoulder to shoulder and do that visit? And sometimes the nurse will be like, I never thought about phrasing it that way. Our number one thing is, when are they going to die? I'm sure you get the question all the time. We don't know any more than you know. So our thing is very careful sidestep. That's in God's department. We'll call the chaplain. No, sorry. Or we prognostically, we have certain things we're looking for, right? There are certain things, and these indicate that there'll be a number of hours to a number of days, and how you gently talk to the family about that.
All right, Chris. Lovely. I'm sorry I kept you a little later than I'd expected, but I really appreciate you joining us today.
Thank you so much.
All right, folks. Have a wonderful weekend. Toodles.
Okay, bye-bye.